So good evening. My name is Tim Gibbs with Delaware Health Force. And this evening, I'm joined by our Executive Director for the Academy DPHA, Dr. Kate Smith. Christy and Nicole are both off dealing with other things this evening, so we're honored to have Dr. Smith with us. So this is the fourth in the series of mini medical school that we're doing in partnership with Nemours. If you have any problem with the Zoom client, please hop on over to YouTube/Delamed302 and you can watch live there. Just send an email to Sabine, Nicole Sabine at delamed.org, and let her know that that's the way you participated in the session this evening. So at this point, I'm going to turn over to Dr. Smith, and she's going to fill in some details about what I mentioned last week, which is National Public Health Week coming up April 7th to the 13th. Dr. Smith.
Thank you, Tim. Yes, we have 3 contests this year for National Public Health Week, which will be running through the week. The first contest we have is an Instagram contest. We're calling it a public health scavenger hunt. And the goal of this is to show us what public health means to you by taking a picture of something to do with public health. It can be in your community. It can be a public health action. Post this photo to your Instagram. Use the hashtag NPHWDE in your caption. Tag us at Public Health DE and make sure that your account is public. We will go through all of the social media posts and we will choose a winner. There will be judging criteria. I will give it to Nicole and she can pass it out to you. The winner will receive either a new iPad or 1 year's paid membership to the American Public Health Association. Your choice. So the deadline for this submission is April 9th and the winners will be announced on April 13th. We also have a public health t-shirt contest. Design your own t-shirt. Come up with a catchy public health slogan, design a t-shirt that has the slogan or has something about public health. Please submit your designs. And again, I'll have Nicole send all of this out to you. Submit your design by April 9th and winners we will make your t-shirt and we will print them and you can buy them and you can tell all your family and friends that you designed a t-shirt. And the final one is a public health short story contest. Write a short story, a minimum of 1,000 words about how public health has affected you or your community. Submit it. We will judge it and winners will be placed in the Delaware Journal of Public Health the next time that we publish. So those are your 3 options. You may choose all 3. You may choose 1, 2. So good luck. And we hope that a lot of you will be encouraged and participate.
Great. Thank you, Dr. Smith. So just quick housekeeping as usual. This is a Zoom webinar, not a Zoom meeting. That's why you can't see each other and why we cannot see you except at your names. Number 2, please do use the Q&A feature. That's the way we communicate rather than raising hands. Just remember that when at any point during this evening's presentation, you can ask a question. We will probably defer many of those questions until the end of this evening's presenter's presentation, and then he will answer them then. Just make sure that they're not of a personal nature or a family nature. It can be a violation of privacy rights. And what we'll do with those questions, if you forget that little caveat, we'll try to generalize them in such a way that we will make them more anonymous. We will do our level best to address all questions. For those of you who have been here in the previous sessions this series, we have gone right up until 8 o'clock, but 8 o'clock is the witching hour. And sometimes we don't quite have enough time to address all questions. And then the big question, how long do you need to stay? You need to stay through the end of the official presentation. At that point, you're allowed to leave. You will have full credit. However, as you are used to hearing me say, a lot of the really good stuff happens in the Q&A. So we encourage you to stay at least through part of that. I'm going to turn it back over to Dr. Smith to introduce this evening's speaker.
All right, so our speaker this evening has a name much harder than Dr. Smith to pronounce. So this is Dr. Nwankwor. He is a pediatric intensivist at the Nemours Children's Hospital and a clinical associate professor of pediatrics at Sidney Kimmel, which is the medical college at Jefferson University. He is the graduate of the College of Medicine in the University of Nigeria. He completed his residency training in pediatrics at Woodhull Medical and Mental Health Center, the New York University program in Brooklyn, and he completed a fellowship in pediatric critical care medicine at the University of Maryland Medical Center in Baltimore. He holds a Master of Public Health degree from Bloomberg School of Public Health at Johns Hopkins, and he has served as a fellow of the Carnegie African Diaspora Fellowship Program, and currently is a visiting scholar of the Department of Pediatrics, College of Medicine, University of Nigeria. I don't know how to pronounce the city names, so I'm just going to say the University of Nigeria. He is a certified physician executive. He has an interest in global child health and focuses on capacity building and in strengthening health systems and services in the delivery of care for children who are critically ill or injured in a resource-constrained environment. In 2019, he led a team from Nemours Children's Hospital and Cooper University Hospital to establish the first organized pediatric intensive care unit in Nigeria at the University of Nigeria Teaching Hospital. He currently chairs the DEI committee of the Division of Pediatric Critical Care at the Nemours Children's Hospital and is an active member of the DEI committee at Jefferson University. He served as a member of the DEI committee of the American Academy of Pediatrics, New Jersey chapter. He has won numerous academic and community service awards, including Faculty Teaching Awards, South Jersey Magazine Top Doc, African Community Service Award, and the Sidney Kimmel Medical College Dean's Award for Excellence in Education. Dr. Nwankwor, the floor is yours.
Yeah, thank you so much, Dr. Smith, for that wonderful introduction. It makes me feel like someone who is important.
You are.
And thank you. It's actually my pleasure to do this. And my name is Dr. Odiraa Nwankwor. I'm a pediatric intensivist at Nemours. The topic that I'll be talking about today is becoming a pediatric ICU physician from Africa to the US. And I'm actually quite glad and happy to be part of the Delaware Mini Medical School spring of 2025. Let's see, how do I move this? Can you guys hear me?
Using your forward and back arrows on your keyboard?
Yeah, that's what I'm trying to do. Is not you moved when we tried it earlier. Let me end it and then go back again.
Sure.
Just give me 1 second. I'll go back and see why that is happening. Yeah, that's it here. Yeah, why is it? Okay. Let's try back and share it again. So, okay, good. So I'm able to share it again now. So that's beautiful. So I was just saying that I'm really glad to be part of Delaware Mini Medical School of spring this year. The outline I will follow, really, I want to make 2 disclosures. One is that I have a beautiful accent. So if you don't understand what I say, please just go to the chat and put in the, tell me what it is. I'll figure out a way to answer you. The next disclosure is that I have loads of slides. So I'm going to try to fly through them. There are mainly pictures, but, I'm going to try and see if I can get to the bottom of it. All right. And the outline I will do is to kind of, just based on the topic that I'm talking about, I'm going to start with Africa, where I did my medical school, tell you guys what I did in Nigeria as a medical officer, and then what I did when I went to Europe, Ireland, Dublin to be precise, and my training in the United States and what I currently do. And then I'll go back again to Africa. We started from Africa, we're going to go back to Africa. And I look at my journey as a triangular journey, that if you look at this world map, This is Africa. This is where I started from, my medical school. I worked briefly and then moved to Europe, Dublin precisely. Beautiful place, actually. Trained in emergency medicine in Dublin, and then came to North America, United States, and did trainings again. Trained in pediatrics in residency, critical care in fellowship, and an MPH in between. And then I'm doing a lot of work now. My focus, now, the big thing that I do now is giving back to Africa, giving back to Nigeria, where I'm originally from, and we'll talk more about it as we go ahead. So that's my medical school in Nigeria. It's a little bit blurry. I tried to make it sharp enough, but it wasn't. So this is University of Nigeria Medical Teaching Hospital. That's where I did my medical school. This is their new site. When we were in medical school, it wasn't at this site, it was at the old site. But that's what the entrance looks like at this point. What is important for me to let you guys know is that in Nigeria, our medical school is 6 years. But my cohort spent 7 years. The reason why we spent 7 years was that there was an industrial strike, which might be a little bit strange to you guys. Industrial strike is when workers down their tools and they don't want to go to work. So in Nigeria at that point, they were not paying our professors. The government were not paying them, and they stopped working in addition to all the other staff of the university, and they shut down the university. So we lost 1 year. So instead of 6 years, we spent 7 years in the medical school. The other difference between our medical school and the US medical school is that for us in Nigeria, we go straight from high school to medical school. You know, we don't go to college first before we go to medical school, which is kind of good. But if you look at everything, it might end up being the same, maybe a loss of 1 year or additional 1 year if you're in this country. And when I finished medical school, I had to do what is called an internship. An internship is a 1 year program, but it's mandatory for any medical graduate in Nigeria. For you to get your license to practice, you have to do the internship. So I did that at the Army Reference Hospital in a city called Kaduna, state also called Kaduna. It's a 1 year program. And after that, I went on to do what is called a national service. This is a program, it's a paramilitary program, and it's compulsory for every single graduate in Nigeria. The moment you finish your college, you must serve 1 year. They post us to different parts of the country. I'm from the Southeast, and I think I was posted to the Northwest. You know, they do that to have like some sort of integration of the so-called youth or adults, young adults. So I did the national service at a hospital in Kebbi, in Kebbi State, one of the states in Nigeria. And then I came to Lagos and started working as a medical officer. I worked in a couple of private settings. While I was doing that, I also got an MPH from the University of Lagos College of Medicine. And I was also involved in some sort of vaccine marketing. The reason I kind of bolded this is just to say that this was one of my MPHs. I actually have 2. So I was trying to make an emphasis, but I got my first one in Nigeria. And then I left to go to Ireland after I worked for a couple of years in Nigeria. I trained in emergency medicine in Ireland. The first hospital I worked in Ireland is called St. Columkille's Hospital. Is in Loughlinstown, County Dublin. I trained there as an emergency room doctor for 1 year. And then I moved over to the Adelaide and Mead, that's what it's called, Adelaide and Mead Hospital, Dublin, incorporating the National Children's Hospital. But I was looking now, and they've changed the name to Tala Hospital, Tala University Hospital. It's actually an academic affiliate of Trinity College, Dublin. So those are the 2 places I trained for 2 years in emergency medicine. It was one of very good times in my life, because while I was doing that, I started preparing to come over to the United States to do my residency. And in preparation for coming to the US, I had to do the US medical licensing exams. We have what is called the USMLE, United States Medical Licensing Exam, Step 1. We have the Step 2, clinical knowledge, Step 2, clinical skills. At the point we were doing this, the clinical skills you must do in a city in America. So I did the first 2 steps in Ireland and came to I think it was Chicago, and then did my clinical skills, and I started applying for residency. I don't want to go into how I cramped this up, but it was a kind of a smooth sail for me, but I cramped it up within months. And I was able to do all those exams and started applying for residency. And then I got interviews, came and did my interviews, and then I matched. I matched to do a pediatric residency in New York. And along the period that I was doing residency, I had to do what is called a ECFMG certification, is Education Commission for Foreign Medical Graduates. Any foreign medical graduate that comes to America for training must be ECFMG certified. I think that's what part of what allows you to register as a medical practitioner in America. So I had to do that during my residency. And this is where I did my residency in New York. It's Woodhull Medical and Mental Health Center in Brooklyn. Our pediatric residency program is a 3-year program. We have what is called PGY1. PGY means postgraduate year 1, and PGY2, PGY3 for the 3 years. And at each of those stages, we do what is called an in-training exam, ITA. I had something I put in very smaller letters. I did that at the end of our residency. I graduated best resident, not because I was scoring the highest on the in-training, but because the program and everybody around then thought that I did a good job. So I got the best graduating resident. Sometimes I try to, I'm so proud of that, and I boast a little bit about that. So that's why I put it in here. And then right out of residency, I was hired at Nemours to work as a primary care pediatrician. And I started off at Georgetown in Delaware, South Delaware. And then from Georgetown, I moved to Milford. The reason I boarded Milford was that was where I stayed the most. And I was what is called a physician in charge of that office. With an office, there's another office manager. So myself and the office manager were like the key leaders at that office. And I lived in Milford, nice, quiet place. I lived there for about a year, and then I moved to Newark. My wife was running a PhD program at the university then. Then we had to move to Newark, Delaware. And the hospital or primary care leadership was gracious enough to allow me to go around other primary care office in the north of Delaware to reduce my commute to Milford. So sometimes when they have someone calls out, or if they have an opening, they can send me to Philadelphia Pike office. I will go there. And at some point, they gave me the yellow model in the hospital to cover on Fridays. So that made me reduce my commute, because from Newark to Milford, where my office was, like an hour plus drive, an hour plus back. So it was a long drive for me, but the hospital has been so gracious for me since I joined Nemours. And while I was doing that, while I was doing primary care, I also moved and got an MPH from Johns Hopkins. And I worked at Nemours as a primary care physician for 3 years. The reason I did that was that I came to this country on a visa called J1 visa. J1 visa is a training visa, but it has a proviso, and it is that at the end of your training, you have 2 options. One option is to go back to your country and stay for a minimum of 2 years and reapply to come back to America. Or you could choose to work in an area that is considered a health professional shortage area for 3 years in this country. If you did that, you get your permanent residency card. That's what is called a green card. So I chose the latter. I chose to work in an area called considered a health professional shortage area. And Milford, Georgetown, Milford, they fell into that category. And I had to do the 3 years. And at the end of the 3 years, I got my green card. And then I left to do a fellowship. And like I mentioned earlier, when I was in primary care, I also went ahead and got a Master's of Public Health degree from Johns Hopkins Bloomberg School of Public Health. So this will be my second MPH. That was actually why I bolded it in the first, in one of the slides. So our MPH then is a 2-year program. It's a combined online and in-person. And the in-person for me then was going for their institutes. They have what they call the Winter Institute, the Summer Institute. And I would go for those institutes and pack up my credits just to let me, allow me graduate within 2 years. And then right after I got my green card, towards the end of my 3 years of working as a primary care attending, I got a fellowship training in Baltimore at the University of Maryland Medical Center. And I went there and then started my pediatric critical care medicine fellowship program. Again, another 3 years program. Remember what I said about PGY? So this one is now PGY 4, PGY 5, PGY 6. That's postgraduate year. That's basically what it means. And towards the end of my training there, I called up Nemours again, and I'm like, I'm finishing my fellowship training in pediatric. Okay, do you guys have a position for me? And then the section chief then, graciously enough, talked to a few people about me there. And then they opened up, they told me they had a spot for me, so I came back to Nemours. There were a lot of other things in between, but this is the bulk of it all. So I came back to Nemours, but I didn't come back as a primary care pediatrician at this point. I came back as a pediatric intensivist. And this is how our hospital looks now. Our new hospital, new building, new in quotes. It's been there now for a couple of years in Wilmington, Delaware. One of the most beautiful hospitals that I know in this country, both inside and out, and the services that we provide. And I showed you guys on the right what a pediatric ICU at Nemours would look. It looks calm, it looks serene, but this is when you do not have a patient in there. But that's exactly how it looks, actually. And at the point I was being hired, Nemours was going into a relationship with Cooper University in Camden, New Jersey. And that relationship included pediatric intensivists covering their pediatric ICU. So when I was hired, my position was to work at both places, work at both Nemours and Cooper, but working at Cooper as a Nemours employed physician. So I was going at both places, but I did more time at Cooper at that point. So that's why I put up the picture of Cooper University in Camden. They're going through a lot of renovation. The place is looking even more beautiful and will look even better by the time they finish all their new modeling and all that. I kind of showed a pediatric ICU room, but in full disclosure, this was not at Cooper though. This was a picture I put up online of what happened, what a typical pediatric intensive care room looks like. But I think it's from Hopkins, most likely, based on what the website says. So I'm going to pivot now. I've kind of told you guys about my training, from Nigeria, worked in Nigeria, went to Ireland, came to the US, did all the training. But I want to talk a little bit more now what we do as intensivists, as pediatric intensivists. There are three major things that we do. One, the most of it is we are clinicians. We treat children who are critically ill. That's the bulk of most of what we do. We are also teachers. We teach medical students, residents, fellows, nurses, allied health professionals. And then we're also encouraged, depending on one's interest, to also do research. Now, a couple of our faculty members are basic science research. We call them bench researchers. Then if you don't want to do that and you want to do clinical research, that is also allowed. But the idea is that if you're in an academic center, you should do some sort of work that you share with academic community, and that helps you to get your promotions as you go along. So what does a pediatric intensivist actually do? And why did I choose this field? So from what I've been saying earlier, a pediatric intensivist is a pediatrician who is specially trained to treat children who are critically ill or kids who are unstable. The critical illness usually could come from organ system failures, or it could come from one recovering from major surgeries or being involved in major accidents. And these kids are admitted in a medical home. We call it a pediatric intensive care unit. And one will be wondering what actually will make a kid to be critically ill or unstable. A couple of things, but I just listed a few that you guys might be familiar with. Kids that have very severe asthma that develop what is called status asthmaticus. You're treating them, they're not getting better, and their clinical state is getting worse. We'll bring them in the ICU and treat them. Some kids that have complications from diabetes mellitus. The commonest complication that brings kids to our ICU is what is called diabetic ketoacidosis. It's an acute complication of diabetes where they have so much production of acid in their blood. That's one of the things that we do in the ICU. And then kids who have overwhelming infection, not just any infection, but infection that is going out of bound. We call it sepsis. They also come to the ICU. And a typical example that I guess you guys might know is pneumonia, but it has to be like severe pneumonia that is causing overwhelming infection or that is making the respiratory system to fail. Those are the ones that come to the ICU. And also kids who are involved in major accidents. ATV accidents, that's the ones that I see that I really very worrisome. Car accidents, motor vehicle accidents, bicycles, scooters, skateboards, rollerblade. The one that I really worry so much about is near drowning. And I made this emphasis to say that we're approaching the summer season. I would encourage you and your family members to be careful swimming. And if anybody is swimming, someone should be around. I've seen bad. I dread it, actually. I do dread it. And it's worse during the summer. But see, these are some of the cases. There are a lot of other things we do, but these are some of the things that we admit in the pediatric intensive care unit. The other things that we do, which I kind of really like, is what I was telling you guys earlier, that if someone is having failure of their respiratory system, let's say from severe pneumonias, we usually intubate them and monitor them with ventilators. Intubation is putting a tube, we call it a ET tube, endotracheal tube. We put it in the mouth through the airway so that we can take over the breathing for that child and continue to treat the child until the lung heals, and then we'll take the breathing tube out again. If you see this child now, this child is intubated. This is the ventilator here. This is the ventilator that we use to help the child to breathe. And these are our monitors here. The monitor will show you the heart rate, the blood pressure, the respiratory rate, the oxygen level, stuff like that. And these are pumps that we use to deliver medications for these kids. If you look closely, and I think I took this picture at Cooper, if you look closely, you see where we wrote critical airway. So this child is not just intubated, but the breathing tube is in a position where you have to be really careful. These are kids that you always have to hang around, in case any issues, you can go in and settle the kid out. The other things we do is that we put special catheters in the blood vessels, and some of those catheters could actually go into the heart. The reason we do that is that there are medications that you cannot just give on ordinary IV. They have to go into bigger vessels. And for you to do that, you have to put these catheters in those big vessels. That we call them central venous lines or central venous catheters. Technology has actually improved a lot of ways that we do this. We do them now ultrasound directed, so you're not doing them blindly. You use your ultrasound and you're able to actually precisely locate the vessel and then use your needle and it will guide you. This was me, and I think this was at Cooper, teaching one of the residents what to look for on the ultrasound to locate the vessel and to cannulate the vessel and all those kind of stuff. So the resident was watching, I was trying to let them know that, like, you remember what I said earlier, that apart from working as a clinician, treating this patient, we also teach, so that's part of what I was trying to do there. This was a happy resident. I can't remember, I think she was on the picture on the right, I think she was her 3rd year, and she was able to put an arterial line. See, that's a patient's hand. So we put arterial lines, we put a catheter in the artery, in the radial artery. I don't know if you guys, you are, maybe your health class or anatomy, I don't know if you do anatomy or health class at this point, but there are 2 major arteries in our forearm close to the wrist. One is the radial artery and the other one is the ulnar artery. The radial artery is bigger, and that's, we normally put catheters in them to help us to monitor blood pressure continuously. That's every minute, every second, you're looking at the accurate blood pressure. You don't have to put a cuff anymore. So this resident did this one for the first time. She successfully did this and she was excited. And then she took a picture. She took a picture showing her excitement. It's actually quite exciting what we do in the ICU. And remember what I said earlier, that apart from organ system failure, that will take care of kids who have undergone major surgeries. I didn't pull up this picture to scare you guys or anything, but this is like an extreme of post-op care. This kid actually has had open heart surgery. That's the reason why you have a lot of these big tubes everywhere. This is an open heart surgery. This is not meant to scare you in any way. Most of our post-op care kids do not look like this. This one is a kid that had an open heart surgery. But again, these are some of the kids that we'll take care of. At DuPont, open heart cases do not come to the medical surgical ICU anymore. They have their own special unit called CICU. cardiac intensive care unit. That's a special part of it. So in our own ICUs, we no longer take care of this sort of kids. They stay in their special units called CICU, so that the physicians there are only focused on the heart alone. When I was in fellowship in Maryland, our unit was a combined unit. We do both the heart, medical, surgical. So these things are all different depending on where you are, but in your fellowship, you're trained in all those. But if you want to specialize in just cardiac, then you can as well do this. So please don't think that every ICU has a post-op case like this. No, don't want to discourage you in any way. And again, we talked about taking care of kids who are involved in major accidents. Yes, so that's also what we do in the ICU. The picture on the left is a CAT scan of a kid who was involved in an accident. And we do this CAT scan of the brain to see if there's a bleed. So when they come to the hospital, in the trauma bay or in the ED, we'll get a CAT scan of their head. If you look at the picture on the left, this is the brain, this is the skull, this white and all around is the skull, this is the skull. But if you look closely, you're going to see that there is a whitish segment that almost looks like a convex portion of this. This is blood in the brain. This is blood. And this sort of blood, the vessel that it comes from is an arterial vessel. Is what we call a middle meningeal artery. So that vessel keeps bleeding when it is ruptured. And if it keeps bleeding, it keeps accumulating this hematoma. We call it an epidural hematoma. And if you don't do anything, it will keep pushing the brain, and the kid will run into trouble. So kids that have injuries that come to the ED or the trauma bay will get a CAT scan. If you see this sort of stuff, the neurosurgeons will take them to the OR or at the bedside and put a borehole. They'll put a borehole through the skull to drain out this blood, and then they'll bring the kid to us in the ICU to monitor them closely. The other CAT scans that we do is the CAT scan of the body, of the rest of the body, to check for any sort of trauma. Let's say that the kid is involved in a major motor vehicle accident. Apart from doing the CAT scan of their head, we do CAT scan of the lungs, of the liver. This substance here is the liver. This is the spleen. That's the kidneys. That's a little bit part of the kidneys, and this is the spine. So we do all these CAT scans. We also do of the pelvis. We do them to look for any sort of trauma, because it's super important that you know if there's any sort of internal bleed or any sort of rupture of any major organ, so that you're able to detect that, you're able to manage that, you're able to follow the kid through in the ICU and get the kid well. It will be disastrous if a kid is involved in an accident and they don't scan the whole body and they send the kid home and that kid bleeds and dies from internal organ injuries. Some of the other cool stuff that we do in the ICU as well, depending on where you work. When kids are critically ill, their organs and their systems are failing, they usually come to us on ambulance on the road. But if time is of the essence, depending on the degree of the injury, they are usually flown to the hospital. And at Cooper, I did these pictures at Cooper. At Cooper, we have a helipad. We also have it at Nemours, but the helipad at Cooper is at the top of the building. So when we have a kid coming in, they will call for pediatric trauma to the helipad. We all walk up to the helipad, and you go to the helipad. It's actually an exciting thing to see. Let's forget about the fact that a critically ill child is coming. But if you stand at the helipad, you could actually see the skyline of any city around you. So this was in Camden, and if you look behind us there, you see, I think there's a skyline of Philadelphia or some part of Camden. And I came up there and they wanted to take pictures. I said, why not? The lady who was standing by my side here is a resident, but I think she's long graduated. And this lady is one of the pediatric ICU nurses, pediatric ICU. They wanted a picture. I said, why not? Let's do it. And then the moment the aircraft, the helicopter is about to land, everybody leaves the helipad. You come down a bit, and then you stay there behind the door. They will bring out the kid. They will roll the kid down to the door. The moment they get to the door, you take the kid, reassess the kid there before you start moving the kid to the ICU. So it's one of the cool things, really, that we do as pediatric intensivists. We do a lot of teamwork and care coordination. In pediatric ICU, is one of the areas in the hospital that you interact with all the other subspecialties. So you have to have some level of resilience. You have to have some level of diplomacy on how you do your things. I actually sometimes joke that you literally have to be a politician so that you're able to really, work with different teams. If on a typical work day, you might have interacted with the neurosurgeon, the neurologist, the endocrinologist, you might really literally interact with these different subspecialties on a daily basis. So you just have to know how to be a good team member. And then we do a lot of care coordination. This was a kid who I think had some kind of trachea surgery. That's what I'm trying to point out. And this was a pediatric resident who was rotating with me in the ICU, this myself. And the lady behind her, that I think is either a pediatric, is either a resident or a fellow from, I think, either ophthalmology or ENT. That's why they have this thing on their head. It's a light source. I sometimes joke that they look like miners. So they put these things on their head with light to help them when they do surgery. These are like big deal, actually. And the gentleman behind me is a respiratory therapist. And I think this lady is a nurse. So the reason I'm pointing this out is to give you guys an idea of the level of teamwork that we do in the ICU. It's not just us, it's us working in consonance with other subspecialists. Remember that I mentioned that we teach. Yeah, we are good teachers, to be quite honest with you, because that's how we train medical students, residents to get to be good doctors. We do those teachings in formal, informal ways. This was us making rounds. In food school, I'm not sure I showed this resident. I'm not sure I told them I'm going to use these pictures, but I don't think it really matters. It's just to convey some points. So this was me with one of the residents. They will present the case to you in ward rounds. They will normally do morning ward rounds, also night ward rounds. But morning ward rounds are usually really like strictly formal. And in those rounds, what we do is to talk about the patient, make plans for the day for the patient, and then take that opportunity to teach the residents. You teach them about some clear topics, but you try to relate it to the patient. That's the way that it's supposed to be done. That's how they end up being good doctors when they do their PGY1, PGY2, PGY3. And that's all you are going to see there. I also joke with residents that I tell them that I take my time to teach you guys because I do not know who you will treat. It could be my relative and I don't want you to kill them. So I make sure that we'll train you properly. As a matter of fact, my youngest child years back, when I used to live in New Jersey, I was sick one night and I took her to the ED at Cooper, and the person I saw there was one of my residents. And in my mind, it was like what I joke with you guys: if I did not train them well, they treat my child and they don't treat the person well. It's a joke, but it's true. And that resident that she saw in the ED then is now a pediatric attendant and actually a new medical director of one of the pediatric ICUs in Florida. So we as attendants do a lot of teaching and a lot of training for our pediatric residents. This is one of the other things that we do in the ICU. We monitor. ICU is all about monitoring. And we monitor patients every minute, every second, all the patients. The beautiful thing about these monitors, these are like equipment now, is that sometimes you do not literally have to sit at the patient's bedside. All ICUs, pediatric ICUs, usually would have a central monitor where all the patients' monitors are being collected, and they're usually around the nursing station. So let's say that I'm not in patient room 1. I could just sit in the nursing station and be watching this. And when I watch that, I will know which patient is not doing well. Then I will get into the room. When I teach in my rounds, I also let the residents know that one of the things that will make an ICU attendant to stand up right away is that if you tell them that the vital signs has just changed, as an ICU attendant, if you tell me, oh, the vital signs suddenly changed, I will get up. It doesn't matter what I'm doing. I have to go and look at it. If you look at this patient now, this is the heart rate. This is the respiratory rate. This is the blood pressure. If there's a sudden change, this is 131, suddenly it goes to like 170, something is wrong. You need to go in and look at the kid. Respiratory rate is 56, suddenly it goes to like 10. You need to go in and see what is happening. So these monitors are super, super important to us. And it's not just looking at absolute numbers, it's also looking at the trend. Looking at the trend, what is happening? Has it been that way? Look at this kid that is 53. Look at the heart rate 53. Look at this one, 131. Somebody will say, but why is it 53? What's happening? I might not be too worried if I would have looked at the trend. Who is this patient? How old is this kid? What is the trend? So these are the sort of stuff that we're trained to do, and it's actually quite exciting when you just sit somewhere and look at the monitors, and it helps you to decide, oh, which patient is not doing well, which patient is getting better, and these monitors are also equipped with alarms, and the alarms, you could set different levels to alert you. Let's say that you're not looking at the monitor right away, you're reading something, you're doing something, and the alarm beeps. You should be able to get up and look at the monitor or go straight to the patient and figure out why. Why do I do this? I will give you this short story about this kid. This is why I love being an pediatric ICU doctor. This kid, I think at that point, he was like 11 years old or something, 10, 11. It was a summer period. He was in the beach, and another kid threw a bocce ball to the back of his head. And of course, he collapsed right away. And he was flown to our hospital. Of course, they will let us know that this sort of kid is coming. I went to the trauma bay, and then the neurosurgeon was there. We saw the kid. The kid was intubated already. And then the CAT scan showed that he has what is called a massive subarachnoid hemorrhage. Remember that kind of scan I showed you guys before? That one is a epidural. There's another one called subarachnoid hemorrhage, very big stuff. And the trauma surgeon quickly did a borehole. I mentioned that earlier. He made a drill in his brain to evacuate some of the bleed, and then left an intracranial monitor. It's a monitor that helps us to gauge the pressure of the brain, or the pressure inside the head. And the kid was sent to me in the ICU. He came to the ICU sick. I had him on a couple of medications to support his heartbeat. And I did not leave. I stayed. Around about 4 or so in the morning, I was in his room. For some reason, I don't know, but I was literally in his room. And then he coded. Coding means his heart rate dropped. And luckily for him, I was right there. And I quickly called a code right away, and folks came in to help me, and we jumped on his chest and started doing chest compression on him right away. And the dad was there when it was happening. I had to ask him to, kind of leave the room so that we can treat the kid. We coded him, and I called what is called ECMO. ECMO is a machine that functions like heart and lung outside of the body. So I called for ECMO. So when you call for ECMO, when you're doing CPR, it's called eCPR, ECMO CPR. And luckily for this boy, the cardiac surgeon that does this type of ECMO is a different type of ECMO. I think he lives close by. I called him and I asked him to come in right away. And then we called the ECMO team, and everybody was on time. They came in right away and then put this kid on ECMO. This was at Cooper. And Cooper is a big teaching hospital, but with a small pediatric department. They do adult ECMO, but they can't do pediatric ECMO. So what we did was to put this kid on ECMO, and I called my hospital, that's Nemours, to come over. So they came over right away in the morning, and then we moved the kid from Cooper to DuPont. And I came back to DuPont, taking care of him at DuPont. He did fantastically well. He had a second bleed at Nemours that kind of set him back a little bit. But overall, he did well. In fact, the father was doing what they call, there's a program that they do at Nemours, like a radio program. And the man couldn't stop talking about what we did for his child. He precisely mentioned my name because I was the one who was in his room when he coded, and the father was in that room when the kid coded. So he was very, very grateful for what we did for him. I took this picture at Nemours cafeteria, because if you look behind me, you see our coffee maker at the cafeteria. This is a kid that almost died, that literally almost died. This kid coded, but look at him. He had some minor deficit, but look at him. This was in our cafeteria. And I tell myself, why do I do this work? The reason I do this work is for kids like this, to be quite honest with you. Now, I'm going to pivot again, and this will be the last part of this talk. I've talked to you guys about how I became an intensivist. I've talked to you about what I do as an intensivist. Now, let me go back to the project that I have now, which is actually what I spend a lot of time doing. I told you guys that I'm originally from Nigeria. I am a naturalized US citizen, but I have this project as a way of giving back to my original country. In Nigeria, where Nigeria is the biggest country in Africa, we're over 200 million people, but we don't have one single organized pediatric ICU. And the under 5 mortality rate in Nigeria is astronomically high. It's about 111 per 1,000 live births. And what that basically means is that 1 out of every 8-9 Nigerian child will not live to see their 5th birthday. So I went back and studied why this is happening. I knew that the primary prevention is there. They are doing well with immunization. They are doing somewhat well with general health promotion. But there hasn't been so much emphasis on secondary and tertiary prevention. Secondary prevention, early detection, prompt treatment. Tertiary is limitation of disabilities and rehabilitation. They haven't been doing much, at that level. So I thought that I've got one of the best trainings in America. Why not bring it down to Nigeria and try to help and see over time if the under 5 mortality rate will go down? And I thought that one of the ways to do that is to start a pediatric ICU. And I went to Nigeria. And I thought also that the best place to do that would be at that medical school where I trained, where I showed you guys the picture when we started. Because that was my medical school. I know the people there. The head of that hospital right now was my classmate in medical school. So I knew it was going to be easier for me to do one there and see if it succeeds. What we call a proof of concept. That if it actually succeeds, then we can now scale it up to involve all the regions in the country. Anyway, I put this picture up to show you guys our Nemours ICU. And on the right is the space they showed me that we can do the ICU when I went to the hospital. This is, you can see, it's almost like a rundown. Nothing bad about the hospital, but it was like, just look at the picture anyway. So I came back here. I knew also that I don't have to ask the hospital to get the money to buy the equipment. If I did that, the project will be dead on arrival. So I thought I should be able to source those equipment myself here, take them down there, set up the ICU for them. I kind of took them away from, took some of the resources away from them just to do this and prove that it can work. So I came back here, I spoke to people at Nemours, I spoke to people at Cooper, and then they started giving me every single medical supplies, medical equipment that the hospital no longer needs. At some point, I considered myself as a medical scavenger because anything that nobody needs at the hospital comes to me. And then I rented a public storage and I was packing them there, loading everything. So what I do is that some Saturdays I'll ask folks to come and help me to pack, sort things out, load things out. This was a medical student. I think she's finished her fellowship now. This is one of our ICU nurses. This lady is, Jen was a resident. She's an attending now. And this is one of the husbands of one of our ICU nurses. So everybody comes. So we do this on, a lot of times. This was 2019, and this is a third packing event, which means we've even done the first, we've done the second, So I asked folks to come out to help me to pack and load and what time is it? Anyway, so they come out, they help, and then this is loading. This is the first container we sent to Nigeria, 40-foot container. Don't ask me what happened when they saw this at the Nigerian Port Authority. This is a mannequin, but it looks like a human being. I heard it was scary for them when they opened it up. But we'll send this container to the University of Nigeria Teaching Hospital. This was the container at that hospital in Nigeria, my medical school. This is them offloading these beds and everything, and then they give us a warehouse. This is the warehouse. These are my team members who came to Nigeria. This is myself. This is one of our ICU nurses. This was our ICU attendant who was actually my boss. This was the guy that hired me when I came to Nemours. He was the chief of the ICU then. This was our pediatric surgeon. So my team members who came to the storage unit, they gave us all our supplies were there and they were intact. And then we went to look at the site. So when I went to Nigeria and they gave me that site, I made a request of them. I told them that I wanted them to pipe in oxygen suction and medical air through the wall. That's what they did there. And I also wanted them to remove those windows and put airtight windows and air conditioners. They did all that. But that's how the ICU was looking when we came. And then the next day they had finished up everything. We started moving our beds and all that. And this is how it looks within 24 hours, the picture on your right. And then we started training them. We did a lot of training. This is myself. This is Dr. Strajewski, again, the guy who hired me for this job that I do now. He no longer is with Nemours, but he was the section chief then. This was some of our nurses teaching the nurses in Nigeria. This was the surgeon showing them how to do intubation. This was Dr. Strajewski, again, working with Dr. Mindy Dikama, one of our ICU attendants, showing them how to do those central lines. This is an ultrasound. This ultrasound machine was at Nemours until we bought the touch screen, and they gave me this one. We sent it to Nigeria. This is how much Nemours has been very instrumental in helping us set up this ICU in Nigeria. So the first time we went to Nigeria was 2019. We were supposed to go back in 2020 and COVID hit, so we couldn't go back. We now started Zoom training for them. And then 2021, they formally opened the ICU. It was a formal opening. I couldn't go there. They called me on Zoom, on video. I joined them on the video. It was actually, the time difference was much. I was actually sleeping, and then they called. So I kind of spoke to them. It was a big deal for them to formally open the unit and started taking in patients. We went back again in 2022. This time around, we were doing training for them and other doctors from other peripheral teaching hospitals. And we continued the teaching, but apart from the teaching, we started also joining them to do clinical service. This was some of our medical team from here that I took to Nigeria, taking care of this kid. And this was the pediatric surgeon, Dr. Doug Katz, assessing this kid. I think either this kid was being prepared for surgery, or this was a post-op care or post-op round. But this was my team in Nigeria. This was my team again, myself, Dr. Michael Canary from Yale. He came to join us on that trip. And this was one of the emergency rooms of one of the teaching hospitals there. This is us making rounds, and this doctor, I think, is one of their own resident doctors presenting the case to us. This is us again, kind of. I like to do bedside teaching. So anytime I see an opportunity, I like to talk to young doctors. I like to tell them what we know and how to do things in the correct way. This was our team again, taking care of one sick kid in that ICU in Nigeria. This is our team member, this is Dr. Doug Katz, joining the Nigerian team to do some of their surgeries there. We also had Dr. Purohit. He was the pediatric anesthesiologist. He must be somewhere there. This was my team that went to Nigeria in 2019. This was the team, great team. One of the occasions that they invited us to the State's House before we left, I met this Nigerian local apparel for them, and they all look really, really, cool and cute in the native apparel. This is my team that went in 2022. It was a bigger team. There were about 15 or 16 of us, like really, really big team. I made another local apparel for everybody. And just news, we are going back on March 28th this month. So next week, we are going back to Nigeria to work with them again and train them. So sometimes, initially when I started this project, I had an intramural grant from Nemours that was supporting travel costs for our Nemours team going to Nigeria. At some point, Nemours no longer has global health outreach. So I do not have those grants again. So one of the things we do some fundraisers to support our travel. And this was one of the fundraisers last year. This was 2023 last year. We just did one on February 19th this year. So it's called a guest bartender fundraiser. We come to somewhere in Wilmington, Delaware, BBC Tavern and Grill in Greenville. We pretend to be bartenders, and then we're serving drinks, and people are giving us tips, and then we'll do kind of online fundraising. It's usually, we get good money for that, to help us to travel to Nigeria. So I just thought that I should show you guys too, one of the things. So we don't just work in the hospital, we also know how to serve drinks if we're going to get some money to help with our global health project. All right, so we're almost coming to the end of this, but what I thought I'd try to do was, first of all, tell you guys about my training to be a physician in Nigeria, tell you guys what I did when I went to Europe and what I did in America here, and getting me to be a pediatric intensivist, and also talk to you about my global health work. Remember the triangle that I said my travel has, or my training has taken me. But let's come back. Let's come back again to why I think we're doing this. I think part of this is to just try to encourage you guys, for those that will have interest in any sort of medical profession. But if for any reason what we are saying here excites you, and you want to be a pediatric doctor, or you want to be a pediatric critical care attendant, this is how the route in America goes. You do your college for 4 years, you go for your medical degree for 4 years, you do your pediatric residency training for 3 years, and you don't have to do a fellowship, but if you want to be an ICU attendant, you go for fellowship. Remember that I finished residency and I worked as an attendant in primary care for 3 years before I went to do fellowship. So fellowship is just a choice. Residency training is not, because you need that to be able to have your license to practice. So if you want to be an ICU attendant, this will be the route in this country that you're going to go through. So why critical care? Some people ask me, really, why did you choose critical care? My answer really is that critical care chose me, really. At another time, we could talk more why I say that. But I love that I'm a critical care pediatrician. It's quite rewarding. I showed you guys a picture of this kid who almost died, but we were there and we helped him, and he lives. That's one of the reasons that I love this job. And we have good patient outcomes. If somebody asks me to be an adult, I'm going to say this, but please don't take it seriously, but to an extent it's true. If somebody asks me to be an adult intensive care doctor, I will say no. I want to be a pediatric intensive care doctor because most of our patients live. Children have very high resilience. They live. I don't know about adults, and that's where I'm going to leave it. And we make a difference. We really do. I showed you guys what we do in Nigeria. I have so much passion for global child health. If something is making me not happy, and I remember that we're doing this in Nigeria, it kind of gratifies my heart. But I spend a lot of time doing those things, so much time. But it gives me so much gratification, honestly, and that's why I do it. And there are many, 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 many more things anyone can do in this world. You just look at where your passion is. And being an intensivist is a good lifestyle. Let me say this, and I hope there's no other intensivist listening to me, but that's actually true. We work in the ICU. Some people say, oh, no, it's so intensive. Why do you? The truth of the matter is that for the most part, most ICU attendants in this country work clinical hours only 6 months in a year. You can go and look at it. We can stay in the ICU but if you actually tabulate it, the clinical work we do is about 6 months in a year. We have other times that are protected for your teaching, for your research, but the bedside clinical work, really, to be honest with you, is 6 months in a year. And, you do your clinical work for 6 months, you do other things, and you're rewarded. So I think it's a good lifestyle. I'm saying this to encourage anyone who this kind of piques their interest. Is a good place to be. I think I'm going to stop here. I don't know how much time that we have, but this is essentially what I thought that I was asked to do, and I'll be happy to take questions. I'll be happy to interact with you guys more, and I'll give you back to Dr. Smith.
Thank you, Dr. Nwankwor. That was amazing. I kind of want to be a pediatric intensivist now too, and only work at the bedside for 6 months of the year. One of the questions which you kind of answered, but maybe you want to expand on it a little bit more, is why did you want to be a pediatric intensivist? And you did say, the children live typically. Did you want to go into that at all?
Oh yeah, sure. I was I'm going to tell you why, but that is a personal story. It's very personal. It's not generalizable to everybody. When I applied for residency, I applied to GYN, I applied to pediatrics, I applied to internal medicine. But I'm someone who believes so much in providence. I believe strongly that the day God created us is the day He created who we are going to be. And I believe that if you work hard and you pray, that God is going to direct your path. I'm saying this to say that all I'm telling you guys are personal story. It might not be generalizable to everybody. So when I applied for residency, I applied to these 3 areas. I said, God, please, whichever one that you give me is what I will do. And I will know that that's what you want me to do. Back when I was in medical school, I did not want to be a pediatrician. I wanted to be a gynecologist. I wanted to be a GYN doctor. That's what I wanted to do. When I went to the interviews, the doctor at Cook County in Chicago, where I interviewed for GYN, told me, oh, I like you. You sound like a leader. I want you here, this, that. So I actually thought that I was going to match in GYN. But when the match results came out, it usually comes on a Wednesday to say you are matched. You wouldn't know where till the next day. So I saw in my email, you are matched. So happy, I'm leaving Ireland, I'm going to the United States. Then the next day I opened up, it was Pediatrics, New York. At that moment, I knew that that's what God wants me to do, because that was what I want. these 3 areas, show me, anyone I get is where you're going to direct me. And if someone asks me today to be a GYN, I'm not going to touch GYN with a long pole. I will not. I love being a pediatric doctor. And when I was a general pediatrician and I wanted to go for fellowship, again, when I was in residency, we had this doctor who was covering our small ICU then, and he would keep telling us about how he goes to some funerals, and I'm like, what kind of life is this guy living as an intensivist? I don't want to be an intensivist. I'm being honest with you. I'm like, I don't want to be an intensivist. And then when I wanted to go for fellowship, I applied in a couple of places. But again, I believe in providence. I believe that what you're going to be is already there. You just need to work hard. You just need to pray, and your path will be directed. Of all the places I applied, eventually it was pediatric critical care that I got. The moment I got it, I'm like, boom, that is it. You need to come to Nigeria to see the impact that we're making. I couldn't do that if I was some gynecologist somewhere. No, I feel so excited, working as an pediatric intensive. Look at the outcomes that we have. Our kids get sick, but they live. So when I have a critically ill child, and I tell my fellows this animals, when I have a critical ill child and I'm talking to the parents are rattled. They are very anxious, and rightfully so. This is their child. They are not doctors. All they know is that this child is bad. But for someone who is an intensivist, who has worked for years, and who have seen these cases, my mind is at when this child recovers, because I know the child is going to recover. I will tell you, over 95% of our kids recover. So that's where my mind is. And I know that what we do as intensivists is to support this kid's organ system. The body heals. And that's just what the truth is. If it's the head, support the head. If it's the heart, support the heart. If it's the lungs, support the lungs. If it's a combined systems, support them. Doctors treat, but God heals. I know that these kids will heal. So I just sustain their organs and they will heal. And it's from that standpoint that I talk to the parents. And I'm going to tell them to relax. We are here. We've been doing this. This is what we are trying to do. This is what we do. And they should just relax. And the majority of our kids get better. I don't know if adults, ICU doctors are going to say the same. So if somebody asks me, oh, you love being an intensive care doctor? Yes. Go to the adult. I'll say no. I would rather stay in pediatrics.
I like it. Tim, do you want me to keep asking questions, or did you want to ask them?
Well, I'll ask a question of them. So have you ever been on a helicopter?
That's a very good question. I have not. The closest I've gotten to a helicopter is at the helipad, but they have someone who comes up to the helipad with us. The moment the aircraft is coming and they are seeing it, they clear everybody from the helipad. We'll stay behind the doors, and these kids will come. They will roll them on the stretcher, and they cross the doors. The kid becomes mine. But inside the helicopter, no, I have not. And I don't think it's something that I would like to do. I would do it if I have to. Like about how many months ago? I think it was late last year or early this year. We had a 30-year-old kid that has some skeletal dysplasia issue that still needs pediatrics. He was admitted at Cooper, but needs to come to Nemours. I was on call at Nemours, and the kid was really bad. Remember that kid that was intubated that I showed you guys that had critical airway? This other kid, her airway is also critical. They can't even intubate the kid over there. And one of the discussions was, if the kid was going to come, are we going to fly the kid? But eventually that decision was not made till the next day. If that kid was going to be flown and it was me that would go, I'm not going to kick against it. I will go there and do it. But after all these years of being an intensivist, I've never flown in a helicopter.
And like me, it sounds like you're okay with that.
Yeah.
Right. So you've talked a lot, and thank you very much for discussing all the schooling that you've done with the medical degree and the fellowship and the MPH and whatnot. Was all the schooling and programs stressful for you? And at this point in your career, do you ever just feel burnout from your job? And if so, how do you manage it?
Excellent. Excellent. Beautiful question. So has my programs been stressful? I wouldn't say stressful, I would say tedious. When I came to the United States, to New York, to start my residency, my son was born July 9th. I started residency July 1st, and he was born July 9th. And we were new in the US, we were new in New York, of all places, coming from Dublin, so just to put it in context, we were coming from Dublin, docile, beautiful, nice place, to New York, and having a brand new baby 9 days after you start your program. And not just that, he was born a little bit premature. He's actually a sophomore now at Jefferson. He was born a little bit premature, and then my wife was really sick after giving birth, and it was a stressful period for me. That first year, it was really stressful. But after the first year, I think I started cruising, So my residency program, from that time, I came newly, and my second child was born. I thought wasn't that stressful. I thought fellowship was more stressful. The reason fellowship was a little bit more stressful for me was that I had been an attendant for 3 years as a primary care doctor. And after 3 years of being an attendant, I'm going back to training again as a pediatric critical care fellow. So what that means is that fellowship is almost like a glorified residency, for a whole lot of reasons. You're going back to earning little money, you're going back to working under somebody. And at that point, I had 3 children. My wife was running a PhD program. It was financially a little bit difficult. I had to moonlight here and there to make sure that the family is intact financially, or family is good financially. But I can tell you, if somebody asks me one of the best decisions I've made professionally, it is to go back to do fellowship after being a primary care doctor. Because I did fellowship, I did my primary care at Nemours. And I went back to Nemours as an intensivist. And in so many ways, I could tell you the difference. In so many ways. So I think going back to that fellowship, as hard as I thought it was then, was one of my best decisions. And what I tell people, I tell family members, I tell anybody that I mentor is, these times fly. The fellowship was for 3 years. If I was like, it's going to be rough, it's going to be tough, I will still be where I was then, and the 3 years will come and go. But the moment I embraced it, boom, the 3 years is gone. Being a pediatric critical care attendant or any fellowship at all puts you at the apex of what you do. And you can fit in anywhere, So it's also gratifying to know that you've reached the apex of your profession. Now, your last question is whether I feel burnout. I won't say burnout. I will not say burnout. All I know is that I have a lot of things on my plate. But I always look at the outcome. I always look at, okay, so what's going to happen at the end of the day? As I'm speaking to you guys now, this morning I have contacted the US consulate in New York to make sure that all my team members have their visas ready. I am talking to the Nigerian people to make sure that our accommodations are set, securities, all those. So these are things that I do by myself. Nobody asks me to do them, but there are additions to what I have already on my table. I don't think they are not burnout. I know that by the time we go to Nigeria, this will be our 5th year of that program in the country. We're at the point where we need to scale it up now. That's actually what I'm doing right now. I'm going to say this and leave it there. I'm working with Senator Chris Coons, the senior senator from Delaware, and he linked us up with the University of Delaware Nursing Program, Delaware State University Nursing Program, and we are trying to build a fantastic nursing program for the whole country, actually, in Nigeria. So when I look at things like that, I don't mind the time that I put in. The results and the impact is all worth it. I will not consider myself as being burnout, to be quite honest with you.
All righty. So these are somewhat related questions. First off, what's your favorite part about your job? What is the thing that really just makes you smile?
Excellent. It's the patient outcome. It's when families feel grateful that we've saved a kid who ordinarily probably would not live, or probably might live with so much disability. And that child is able to walk out of the ICU. you can't beat that feeling, to be quite honest with you. The reason I'm doing this project in Nigeria at the end of the day is to see if our efforts could lead to a child who would have died live. That's the best part of my job, that I'm able to help to save a child's life, a child who is not just having sniffles, the child that comes in complete respiratory failure, and the child walks out of the ICU. That's the best part of my job.
Ready? So when you're not working, what kind of hobbies do you have? What do you do outside of being a wonderful physician?
Excellent. That's a good question. My son was asking me that before. All the answers I gave him, he would tell me that that's not a hobby. You know, so I like politics. I like current affairs. I like to not just read, I like to follow what is happening around the world. I like policies. I like I like to know what is happening in America. I like to know what is happening in Nigeria. So I spend my time either listening to the TV, reading up on things. I want to know what is up in the country. And the reason I do that is really because at the end of the day, my mind is in policy. How can we influence policy that help people at a larger scale? Like I wake up in the morning and go to the hospital. That's my job. I do it. I love it. But if there's a way that I can influence policy and it helps bigger number of people, that would be my dream. So most of the things I do outside of work is looking at things that are happening around the world and looking at policy. Then I like to listen to music. I love music, all kinds of music. Then every year I go to Nigeria for family and friends visit, nothing to do with the ICU project. And then I hang out with my friends, my old friends. You know, that time is like, I just came back in January. You know, I go there, all I do is hang out with my friends, you know. Then my children, my kids will almost like practically drag me to, my son is in Jefferson here. He will say, oh, Dad, can I come? Tell me the movie you want to watch. I want to come, both of us sit down and watch the movie. I said, okay, let's do it. So the times that the kids come around and they want me to really do stuff for them, fantastic, we do it. But I go to Nigeria every year and I hang out. But I know within myself that my passion is in policy. Is in policy, trying to help people at a larger scale.
Glad that you have that passion. We need more of it. Well, thank you very much, Doctor. Let me go ahead and real quickly share. So next week is going to be a somewhat different mini med in that Dr. Stacy Bachman is going to be presenting with a number of co-presenters, too many to actually list out here. And they're going to be pediatric advanced practice providers. So advanced practice registered nurses, certified nurse specialists, physician assistants, and other types of providers. Everyone, have a great week, and we will see you this time next Wednesday.
Tim, can I ask you a question, please?
Yeah, what's your question?
Yeah, you said that this was being streamed on YouTube, right?
Correct.
Do you have a link? Can I look at it?
Oh yeah, this recording will go up onto Delaware MiniMed after it's been edited.
Okay.
We'll send you the direct link so that you can get there.
Okay. Thank you so much.
All righty.
I had fun doing this. Thank you. Thank you.
Bye-bye.
Thank you.
Bye-bye.